Standard Occlusion Theory for TMD. I am Sotokawa, a dentist practicing in Morioka City, Japan. This theme covers the occlusion theory essential for treating temporomandibular joint disorders, organized into the following 24 topics. This time, I will explain the 11th topic. Occlusal Equilibration. 11. Occlusal Equilibration. Contents. Introduction. 1. Types of occlusal equilibration. 2. Dawson's instruction. 3. Theory and procedures of occlusal equilibration. 4. Treatment goals for occlusal adjustment. 5. Principles of occlusal interference reduction. 6. The significance of the principles of occlusal interference reduction. 7. Principles of mandibular anterior occlusion adjustment. Introduction. Dawson explains the theory and procedures of occlusal adjustment over 25 pages in Chapter 33 of Functional Occlusion. Occlusal adjustment is performed when a patient is diagnosed with occlusal disease, meaning the cause of the disease has been clearly identified as malocclusion. This time, we will explain what occlusal adjustment based on occlusal theory entails. 1. Types of occlusal equilibration. As shown in the chart on the upper right, occlusal adjustments include those performed during prosthesis placement and those for occlusal disease treatment. Occlusal adjustments during prosthesis placement involve unilaterally reducing the prosthetic occlusal surface to harmonize the prosthesis with the patient's occlusal contact position. Since the treatment goal is the current occlusal state, the procedure is relatively simple. Occlusal adjustment for occlusal disease treatment is performed when malocclusion is clearly identified as the cause of the disease. That is, based on the patient's occlusal analysis, it is determined which part of which teeth requires reduction and to what extent. Occlusal adjustment is only initiated after the final treatment goal is established. Therefore, occlusal analysis and occlusal diagnosis are indispensable for occlusal adjustment in occlusal disease treatment. Furthermore, when performing occlusal surface reduction, either the maxillary or mandibular occlusal interference area is selected for reduction. This makes the procedure complex and challenging. On the other hand, Dawson states that occlusal adjustment, similar to that performed for occlusal disease, must also be appropriately performed when placing crown restorations. 2. Dawson's instruction. At the beginning of the chapter on occlusal adjustment, Dawson states the following under the heading Important. A. Do not perform occlusal adjustment if you have doubts about the outcome. B. Success can be predicted beforehand. Occlusal adjustment is a minimally invasive, conservative treatment method. However, careless occlusal adjustment can also cause various problems. Therefore, we dentists must deeply internalize Dawson's brief instruction. Dawson states, incomplete occlusal treatment is far worse than leaving malocclusion untreated. Dentists should not blindly attempt occlusal adjustment with an attitude of, let's try occlusal adjustment. 3. Theory and procedures of occlusal equilibration. Occlusal adjustment is the most widely applicable treatment for resolving malocclusion, offering clear and immediate therapeutic effects. Patients suffering from malocclusion often report feeling easier to bite immediately after receiving appropriate occlusal adjustment based on proper diagnosis. Occlusal adjustment is performed based on occlusal theory, the functional anatomy of the tooth's occlusal surfaces. Although occlusal theory is not taught in Japanese universities, it is not a new discipline. It began with the research of Bonwil and Spee in the late 19th century and has been cultivated and developed by dentists and scholars worldwide to this day. This time, based on the content of Dawson's book, Functional Occlusion, which can be considered the culmination of occlusal theory, we introduce the theory and procedures for occlusal adjustment that are currently considered the international standard. 4. Treatment goals for occlusal adjustment. Dawson outlines 5 requirements for occlusal stability. A. Stable holding contacts on all teeth when the condyles are in centric relation. B. Anterior guidance in harmony with the envelope of function. C. Immediate disclusion of all posterior teeth the moment the mandible moves forward of centric relation. D. Immediate disclusion of all posterior teeth on the non-working side. E. Non-interference of all posterior teeth on the working side with either the lateral anterior guidance or the border movements of the condyles. Immediate disclusion is ideal if achievable. 5. Principles of occlusal interference reduction. To resolve occlusal interference, it is necessary to select and reduce the interfering area on either the maxillary or mandibular teeth causing the interference. The decision on which arch to reduce is based on the following principles. A. Cusp fossa pairs, reduce the fossa. B. Functional cusp versus non-functional cusp, reduce the non-functional cusp. C. Functional cusp versus functional cusp, select the side that does not affect the vertical dimension of occlusion for reduction. D. Incisal edge versus lingual surface, reduce the lingual surface. E. Incisal edge versus incisal edge, select the side that does not affect aesthetics for reduction. 6. The significance of the principles of occlusal interference reduction. By adhering to the principles of occlusal interference reduction, the occlusal vertical dimension remains unchanged while the occlusal surfaces of the molars develop distinct cusps and fossae. Consequently, cusp interlocking becomes stable, and the chewing function of the molars improves. If the cusps of the molars are reduced without following this principle, the occlusal surfaces of the molars become flat. When the occlusal surface of the molars becomes flat, the occlusal surfaces of the maxillary and mandibular molars contact each other as flat surfaces, leading to reduced chewing function. Furthermore, cusp engagement becomes unstable, causing patients to complain, "I don't know where to bite," and worsening occlusal disorders. 7. Principles of mandibular anterior occlusion adjustment. A. The incisal edge of mandibular anterior teeth should generally not be reduced. The incisal edge of mandibular anterior teeth serves as the starting point for occlusal guidance and should generally not be reduced. This is because reduction may result in loss of contact between maxillary and mandibular anterior teeth. B. Preserve the sharp angles of the incisal edges of mandibular anterior teeth. If the angle where the incisal edge transitions from the labial to the lingual surface of mandibular anterior teeth becomes sharp due to attrition, do not reduce this angle to create a transitional contour. This sharp angle serves an effective function in cutting food. Standard occlusion theory for TMD. 11. Occlusal equilibration is now complete. If you enjoyed this topic, please click the like button. If you have any questions or concerns, please write them in the public comment section below. The next topic is the 12. Examination and diagnosis for occlusal equilibration.